All right, everybody, welcome to our new podcast called Endotopic. I mean, who came up with that name, JP?
I don't know. There's a lot of homeless people in the neighborhood.
It's pretty interesting. Endotopic. So we're here with Dr. David Kulber from Cedars-Sinai. Welcome.
Thanks for having me.
Our pleasure. Our pleasure.
Indubitably.
Well, I'm so glad you're here, and I'm so glad we finally get to talk about surgery and what you do and how you help people and what your life's about and how you got into hand surgery. So why don't you first of all tell us who you are and what you do and where you work?
Yeah, so I'm Dr. David Allen Kulber, and I'm a plastic and hand surgeon, and I work at Cedars-Sinai Medical Center in Los Angeles, California, where I'm the director of hand surgery, and we have a very large hand program, and I do a lot of hand surgery and plastic surgery there.
Excellent. Yeah, so the topic of our podcast is endotopic. I mean, the name of our podcast is Endotopic, but it's the cutting edge of surgical conversation.
Yeah, well, and we have
like
a blade, and we it's sharp.
It's sharp, and we cut things.
Use it. Yes.
Yeah,
on the cutting edge.
Yeah, that's definitely on the cutting edge.
Yes.
When we do other podcasts in here, our other guests accidentally cut themselves on that thing. So.
Oh yeah, all the time.
Yeah.
So be careful.
So what have you got in your hands? What is that, Dr. Kulber?
I'm holding a device that I believe it's a Stratos endoscopic carpal tunnel releasing device that I think is right on the cutting edge. Really revolutionized how people do carpal tunnel releases in a very safe and efficient manner.
Yeah, and it's made by AM Surgical, which I happen to run.
Yeah, I mean, that's the weird coincidence of this whole thing. I mean, I sit down and there is a device, and you happen to know that you know what it is.
Yeah, isn't that interesting?
Yeah.
So, tell me the story of like when you first saw Stratos and you were like, I want to look at that thing. I'm interested in it, and also add in a little like, why did you want to do endoscopic?
Yeah, I never wanted to do endoscopic. I thought it was a very dangerous proposition. When I was at the hospital for special surgery during my training, we had done endoscopic releases at the very beginning, and this was back in the 1990s. And we would do them and then open up to see how we did, and a lot of times we didn't do so well. And so I kind of determined at that time that there just wasn't good enough optics for visualization, and I just didn't think it was a safe operation. And then when I went into practice, I saw a lot of injuries from endoscopic carpal tunnels, and I was like, okay, probably not the thing to do, and I just never did them, and I was actually very vociferous against them and wrote an article about why we shouldn't do them. Of course. And the interim, while that article was still being published, or I'm looking through the hand journal and I see a picture of the Stratos device with the clear tube where you can see everything. And I was like, God damn it. Why didn't I think of that? And was very... And it just happened that it was the hand meeting in Seattle that I was going to because we were interviewing for a new associate. And that associate we ended up hiring, Eugene Tsai. I made him
great guy.
And big Stratos user. And I went to right before we did all the interviews that day. I made it a point of going to an early morning lab that your father was running.
Wow. And
doing a cadaver lab and looking at the device. And I was like, I need to see this device if it's really what it looks like, because that's, I think, the answer to doing a safe endoscopic carpal tunnel release.
You'd like to see.
So I did the cadaver lab with your dad. And
amazing.
And I may have met you at the time, but I really was more impressed by your dad.
I don't blame you. I don't blame you. Yeah. He's a pretty impressive guy.
Yeah, and like, who's this Romi guy? I just want to talk to Dr. Mirza. Okay, anyway. So,
story of my life.
And then I finished the interview, and I came back, and I'm like, I need to try this. And so then I think that's when we contacted you, and we started doing it very slowly first. Like we did a couple more cadavers just to get the technique down.
Yeah, and if I remember correctly, we came to Cedars after you said you wanted to try it, brought a lab in, did the whole setup, brought some cadavers in, and then we obviously practiced there first.
Yeah, and then
to get it down.
Got it down, and then I started doing it, and you'd come, because it's very scary when you first start doing it.
Absolutely.
But then it's like, before you know it, you're doing like very high level stuff. And then I just started doing it on everyone. I mean, surgeons, operated a lot of surgeons, big time surgeons, which is a big deal. And other folks and famous people. But then we wrote a paper about it.
Yes.
About how well you can visualize the motor branch and the nerve and see everything. And there's ways to avoid injuring the nerve. And it's even safer than, I think, doing an open carpal tunnel.
Wow.
And so totally changed. And the only little embarrassing irony to the whole thing is the same time the article that came out of how safe it is to do endoscopic carpal tunnels and how amazing it is. The same article that month, the same article came out of why you should avoid doing endoscopic carpal tunnels with my name on both of them. So it looks like a little schizophrenic.
Good timing.
But it really triggered a lot of thought for me. I'm like, man, if Romi could think of like this brilliant idea of like making a cleared tube, I should be able to think of something.
Yeah.
So there you have it.
Yeah, I mean, that's what America's about?
Yeah.
Go and come up with an idea and make it happen.
Innovation.
Something.
Yeah,
Innovation. Yeah.
Making a dream a reality.
Yes.
Yeah.
100%. 100%. I think that's life.
That's
make the dream a reality.
That was the Disneyland ride, the Carousel of Progress.
Oh my God.
If you remember that ride. It was my favorite ride. Man had a dream, was just a start. He followed that dream wide and far, and then it became a reality.
Oh my goodness.
A great big world for you and me. It's a great big beautiful tomorrow. Carousel of Progress. That's how I live my life, man.
Awesome.
Yeah.
Awesome. I wish everybody did.
Yeah.
Yeah.
Okay,
That's
right,
it. The
yeah.
Carousel of Progress. I love it.
Yeah.
Yeah. It was weird for me because I was doing the, surgeries, but in the back of the OR watching and teaching, and we had a metal cannula. And it was driving me crazy because we couldn't see. And they're like, am I in the right spot? Am I doing the right thing? And I'm like, oh my God, this is why everybody's scared of endoscopic. This is why everyone is like, I'm not doing this. Because you have this tiny slit. That's it. And
so
then,
where did you get the idea of like kind of thinking of a clear tube?
It wasn't my idea. I had the idea in my head, but Dr. Suman Sai from Kleinert and KKNA, he came up to me, big man. He goes, make it clear. And I was like, what are you talking about? I was like, what is he talking about? And he takes this test tube and he just jams it in the elbow. And he's like, see? And I was like, that's brilliant. But, we can't use glass. We can't use a test tube. So I went back and I started experimenting with medical grade polymers. And I was trying not to get that straw in the glass effect. Like when you put the straw in the water and you look through the glass, it's displaced.
Yes. Yeah.
Yeah. So that's what I didn't want to happen because we're going into the body. We're going into some fluid, not a lot, but some. So I didn't want that distortion to happen because obviously if you're doing endoscopic and you're right next to the median nerve, you want to know exactly where you're at. And it has to be in real time. So I was like, okay, if we can get the right polymer that's flexible and won't shatter and won't distort the view, but it's still medical grade, that's what I need. And I did maybe 3 or 4, maybe almost 5 years of research. And I finally found the right material, which is the secret.
Yeah.
It's the secret sauce. And then I said to myself, well, why don't we combine it all together? We're already using the scope. Let's put the knife and the clear cannula mounted onto the scope. And that's when things changed. And that's when the Stratos came out.
Yeah.
Yeah. And it changed things a lot, tremendously, because even people who were doing open that were slow to convert, they were like, well, I can see. Imagine that.
Yeah, I mean, I would have never imagined ever doing an endoscopic carpal tunnel until this device. And then it makes so much more sense how you can visualize it. It made sense to me I was at the era where I did full-on general surgery training before I went into plastic and hand surgery. And the person who invented laparoscopic surgery was George Bursey from Cedars-Sinai, who I wrote a lot of papers with. He was an amazing man. He's one of the most famous surgeons in the world because he invented laparoscopic surgery. And when I was a resident, trauma patients would come in and we would put a scope in their abdomen. It used to be you'd have to do like a DPL where you put fluid in and you count the white cells. This is before CT scanners and all that. And before all that, we were doing laparoscopic surgery. Yeah, very in the emergency room. And the thing is, with laparoscopic surgery, you can see way better than when you cut open the abdomen and you look inside. You have a much better visualization through a laparoscope. And that's the whole thing with like endoscopic techniques is that you actually, the irony is that you make a smaller incision and you see more.
Right.
And that's the kind of the cutting edge of what the thought is, and that you don't have to have huge incisions to open everything up to see it. You actually get better visualization using an endoscope. And that was Dr. Bursey's kind of contribution to medicine, is realizing that. And so it always was at the back of my mind because I did some work with him. I wrote some papers with him. We did it like endoscopic, tried to do like an endoscopic brow lift and put the scope underneath the brow. And, you know, wherever Dr. Bursey could put a scope, he would try to put it in. But we never went into the carpal tunnel.
Wow.
But a lot of the devices, the scopes themselves, what you could visualize through the scope is what he designed, like the cameras and all that kind of stuff with Storts, and it was very innovative. So I had a lot of exposure to endoscopic surgery or laparoscopic surgery very early on in my training.
I didn't know that. Yeah, wow. So it makes sense.
Yes.
You were waiting for something like the Stratos to come along, or, you know, something that would convince you to do endoscopic in the carpal tunnel.
When I first, thought about doing endoscopic carpal tunnel very early on, I just felt like the visualization wasn't great and it wasn't safe. But, your device changed it all. I was really quite happy and angry at the same time when I saw this.
I know, you told me.
Yeah, I was like, God damn it! Why? Sometimes like the most brilliant ideas are the simplest.
Yes.
And this is like one of those cases where, just make it clear.
Make it clear.
Yeah. Why wouldn't that be a thought of like?
Why wouldn't everyone do it?
Yeah.
It didn't make any sense to me either. And then one of my prerequisites when I was coming up with it with the design team was like, I was like, we must be able to see as soon as we're going in. Because all the other endoscopic devices prior to this, like you couldn't see when you first went in. You were dilating, you were putting a cannula in, right? So you couldn't see. And it was like, what are you doing? Yeah. It was like a partially blind, then endoscopic technique. It made no sense.
Yeah, putting in a blind cannula or dilator is crazy.
Crazy.
Because there's stuff that can be there.
Yeah.
And there's, the one thing in our paper that we wrote about of why we don't do endoscopic was really because the median nerve's got so many variations. So not everyone is the same. It's not like you could see a bifid nerve. You could have the branch coming off one way or the other. We've taken a ton of pictures where the motor branch is coming off like next to the pinky. I mean, just crazy stuff because everyone's very different. So the visualization's the key to this, and this really solves that problem. So bravo.
Yeah,
bravo.
Thank you.
Yeah, well done. Yeah.
Yeah, and I always tell, when I tell people and I talk to them about what I do and all that, and they're like, oh, it's interesting. And I'm like, you have to think of it this way. Like, we all have our eyes roughly in the same spot. But we don't all look the same. It's the same when you go inside.
Yeah.
Right?
Yeah.
It could be different. I've seen a bifurcation in the median nerve that was proximal to the proximal border of the ligament.
Yeah.
And it's like, what? And it's just interesting, the variation on the anatomy and how you have to be careful, you have to be cautious, but you also have to be able to see.
Yeah.
That's an important thing.
It's
throughout the entire procedure.
It turns out in surgery, that's kind of a prerequisite. Yeah. I mean,
Imagine that.
Not a lot of blind surgeons. I mean,
But no.
yeah, it's a prerequisite for surgery.
Yeah, you have to be able to see.
visualize. Yeah, it's,
That's why you wear your loops.
Yeah, that's why you wear your loops.
It's so true.
It's an important part of it, but it really is a game changer because it used to be like you would have an incision on the palm, and you have the palmar pain. You don't know who's going to have that pain.
Talk about why you don't like to violate the palmar fascia. Interesting.
The palmar fascia is not your friend. It's not meant to be. It's there to protect you and protect your nerves and your underlying structures, your tendons. And it's an interface between your skin and these more important structures. So when you violate it, it just forms a ton of scar tissue. It's not very friendly. It gets very inflamed. Like plantar fasciitis, which is when people get, from walking, that's the same fascia that's in your palm. And when you get it angry, it stays angry for a long time. So imagine having plantar fasciitis, but it's in your hand and you're using it all the time and you're grabbing things. It just, you can't get rid of it. It's very, very unfriendly. It doesn't like to be touched or violated or damaged. It's there to protect you, but when you violate it, it creates a...
You mean cut it?
Cut it, yeah. It creates a lot of inflammatory response, and sometimes it's very detrimental. And that scar tissue is very difficult to get rid of. So you never want to violate it if you don't have to, and that's why it's like when doing an open carpal tunnel or, even trigger fingers, which we could talk about, when you violate the palmar fascia, you get so much scar tissue sometimes in some patients that it's worse than the disease process itself. You wish you never had operated on them and touched that fascia.
Yeah.
It's the same fascia that forms Dupuytren's disease, finger contractures. So if you get scar tissue, it will cause contractures.
Mm-hmm. Yeah, absolutely. So if you were going to talk to one of your friends that's doing open carpal tunnel right now, and you were going to say, look, here are the reasons why I do it with the Stratos endoscopic, what would that be?
The one would be first, it's safe.
Nice.
And the visualization, I think, is better than doing an open carpal tunnel release. And then second would be the consequences of violating the fascia, the palmar fascia, even through a tiny incision. Once you touch that palmar fascia, in some patients, they do great. In some patients, it creates a massive inflammatory response. And unfortunately, you can't decide who is going to get that reaction. It's just variable because we're all very different. But the ones that get that response, it's worse than the carpal tunnel. So,
wow,
you've actually created a problem instead of solving. Maybe you
fixed
solved
one problem,
but you created a worse problem.
Yes.
So, and we've all been there and experienced that. And it's always like a concern when you're making an incision in the palmar fascia of what can happen with that scar tissue and how the patient's going to react. So this is a little more predictable, and you don't have to worry about that, and they do much better.
It's interesting you said that because I always kept the blade low profile, right? Because I didn't want to violate the palmar fascia. I wasn't aware of what you taught me about how it gets really pissed right at you if you touch it. But I was just trying not to cut through more layers than the transverse carpal ligament. And my dad was pushing me to keep the he called it the interthenar fascia.
Okay, yes.
Or the palmar fascia.
Yeah, the palmar fascia.
He's like, keep the interthenar fascia together. I'm like, okay, all right. And he's like, don't violate it. I'm like, okay, all right, no problem. And we did in the design. And this is the brilliance that he came up with that. And and then adding on top of that, what you're talking about, he was doing it because he didn't want to damage anything. But you're saying because of the inflammatory response in some patients, it becomes a huge problem.
Yeah, you get scar tissue from it. So, I mean, I told you your dad's just a much smarter guy. I mean,
he's really smart.
Yeah.
It's ridiculous.
I could tell from day one. Yeah.
He's very smart.
Very smart, yeah. So that's the whole thing with this device. It's great, yeah, endoscopic.
Yeah, no, yeah, makes sense. And the other thing that I picked up is, and I can't believe, like you said, it was that you think it's safer than an open. I'm like, wow.
Yeah,
really?
I mean, I think that just goes down to the fact that you visualize more like laparoscopic surgery, where you could just see everything, and you could see all the tendons, you could see where the nerve is, you could see the you could see the fascia above you, you could see the transverse carpal ligament. You could look around and just see everything inside
before you cut anything.
Yeah,
you're just looking around.
If you see a patient with a lot of synovitis, then hey, I should do a synovectomy. it turns out now that you could the best way to diagnose someone with amyloidosis is doing a synovectomy. And now there's treatments for amyloidosis. So you literally doing a carpal tunnel can save someone's life. Because if you make an early diagnosis of amyloidosis, you could treat them. And otherwise a disease that would kill you, you save their life. So we've started doing that. And we have saved,
Amazing.
It's crazy that you could save someone's life doing a carpal tunnel release, and it's real. A lot of papers coming out about that. We're writing one.
Did you when you do the synovectomy? Do you do it through the same incision?
Yeah, you could just you just need to take.
Is it a tenosynovectomy or just
a tenosect? So you're just taking out the synovium, and you just need like a cc or 2 of synovium, not a huge amount to test it.
Oh, okay.
And so you could do it through the small incision and take it out, and because you've visualized where the nerve is and where the tenosynovium is with the scope, you kind of have an idea where everything is anyways. And then you're able to take that synovium, send it as a specimen, and if you test it for amyloid, it's called a Congo red stain. Congo red staining.
Congo red staining?
Yeah, and if it's positive, then they can do other stains to figure out what type of amyloidosis you've got. There's different varieties, like the wild type. And
What?
It's a crazy, all these different crazy names for it. XKG, amyloidosis. But there's treatments for it, and it kind of basically amyloid gets into your system. It clogs up your heart and it affects your heart and your pulmonary. It kills you.
How does it happen?
It's just your body deposits this tissue. It doesn't resorb it, and this amyloid. So, I had a very close colleague of mine die of amyloidosis. He was a really great guy, Dr. Christensen up in Bakersfield. He used to send me a lot of cases, and he ended up passing away from amyloidosis. Now it's treatable. So I have a personal vendetta against amyloidosis. And
good.
I just want to take that mother out. Okay. So we do a lot more biopsies now, and you could do it through that incision. Sure. You could see it. You look in and you go, oh, wow, there's a lot of synovitis here. Maybe we should, biopsy it and see. And we do that very frequently.
Can I, do I have your permission to teach people that?
Yeah, you should. I mean, it's really important. You're saving lives doing carpal tunnels.
Yes, through carpal tunnel.
Who would have thought?
Amazing. Yeah. It's amazing. And when we teach it, I go through all these different things about the device and the pearls, but that is that's gold. It's amazing.
Yeah, and
you could be saving people's lives doing carpal tunnel.
Yes. Yeah.
My goodness.
Big deal. Yeah.
Yeah.
And then the patients really thank you, because when they first they go, oh, damn, I've got amyloidosis.
Yeah.
Then we're like,
it's treatable.
But now we're going to send you somewhere, and something that you would have probably found out when it's too late, when your heart's already damaged. We're going to get in there, and you'll be able to treat it before that damage occurs.
That's fascinating.
Knowledge is power.
Knowledge is power.
Yeah.
100%. Wow.
Yep.
So you run a fellowship program.
I do.
At Cedars.
Yes.
And when you have new fellows come in, what are some of the pearls of wisdom you give to them for them when they leave, and also for the device? Because it's their first time using it.
Yes.
Right?
So, for all of surgery, the first thing you think of is, what are the complications?
Yes.
Okay, that's number one. Okay, so you have to, before you think about how you're going to fix it and operate on someone, my biggest thing is think about all the complications that can occur. Yes. Because you've got to know all of them and be prepared for all of them, and then decide the risk-benefit ratio of doing a surgery versus not doing a surgery. When it comes to the Stratus device, we go through all the possible variations and things that can happen. And, I like to teach surgery like teaching surgery for dummies, like everything, make it, create steps that are very simple. Yeah. And you just have a series of steps that you do. My mentor, Dr. Cohen, would always say, before you start operating in a place, get all the kids off the street. And meaning know where all your anatomy is, all the things that you can injure, visualize it, see where it is, and then you start the operation.
Interesting.
So I don't deploy a blade until I know exactly where the median nerve is. I have a sense of where the tendons are. And before you start cutting anything, you want to know where everything is. And that's the beauty of the Stratus device, is that you can see everything before you deploy a blade that can do either a lot of good or it could do a lot of damage.
Yeah.
Yeah. So that's really the pearls that I teach them. And then basically what to do when it's, if it's a very tight carpal tunnel, there's a lot of other things to do to work that.
Yeah. I mean, that's awesome. It was awesome. It was great. I mean, they'd be lucky to be under you and getting taught by you.
Well, that's why I won the Guiding Hand Award one year.
A Guiding Hand Award?
The Guiding Hand Award.
Wow. You won that?
I did.
Impressive.
Yeah, well, the residents were all kind of delinquents. But that was the year I won. But, I won still.
Of course, right?
Yeah,
the year you
yeah,
That's pretty funny.
Yeah.
Yeah. Well, I think you're a great guiding hand. I think it's wonderful, and it's really awesome to talk to you about this and pick your brain and kind of see where you're at and what your experience is with it, and it's wonderful. So thank you for your time.
Yeah, we've
really
taught
appreciate it.
other generations of surgeons to use it, and I think it's a very great. Feel very good about it.
That's
just
wonderful.
wish I would have thought about it before you. Okay.
All right. Well, we're going to wrap this up. Dr. Kulber, thank you so much for your time. Thank you for your insight and your brilliance. We're all standing on the shoulders of giants, right? No matter who it is.
We are.
We all are.
Yes.
All of our society, but especially in surgery. The stuff we learn now or we apply now is been taught to us by people who've had those mistakes. So that's what it's really all about, right?
It's just pushing the envelope a little more and just every stage doing it a little better and a little more efficient. And really, it's all for patient care and outcomes and helping people.
Yes.
That's why we're doing this.
That's why I do it.
Yeah.
Yeah. Help people.
And you're saving lives now, too.
Oh, my God.
Yeah.
All right. Well, we're going to wrap this up. JP, thank you very much for running the board. Thank you so much for being here. And we're good. We're out.